Thing on. All right, so good evening to everybody. I know things busy. We got folks needing to do this, need to do that. So we're gonna get going with the class. Just to let everybody know, I got to be ugly for a second. So listen, if y'all haven't caught up with your test, y'all haven't done your test, or y'all are behind test, um, just remember my email that I sent out, that it's your job to contact me, not me to contact you. Some of you, and I say y'all in general, not just particularly anybody, are behind several tests. And I, I wish everybody the best, but I'm not sure some of the ones in the group are still going to be able to catch back up and keep continuing. I know I read it a lot of folks for the last chapter, but y'all may want to log in and get your stuff done if you're missing. Some stuff's going to be locked, and you're going to obviously have to contact me, and we'll talk about it after that. Not trying to be ugly. I've had a few contact me, some haven't. Um, but I'm still waiting on some that's reached out that won't reply to an email. But guys, I just want to make sure y'all all get to registry and get there. So let's make sure you check on your stuff. All right, let's get going. All right, we know our fundamentals. We talk about this all the time. So we're gonna do this. All right. So tonight's chest trauma. We want to make sure you recognize and management of blunt trauma, open chest wounds, and impaled objects. What are we gonna do with those? How do we treat them? What I mean, obviously you're gonna recognize it if it's an impaled object to the chest. Hopefully, that you're gonna remove the clothes and inspect the chest. Not all the time they're gonna tell you that something's impaled, or you just got to do an assessment. Geez, that yawn come early. Woo! I hadn't slept any last. I've been up since 9 p.m. last night. I've had two patients and two air evacs today, so I'm struggling. We're going to talk about the patho, blunt versus penetrating, and hemothorax. You're going to tell me you're going to be able to see what's the difference in those, and we'll show you some pictures on that. We're going to go over the pneumothorax as open, simple, and tension pneumos, simple pneumo, open pneumo, how to manage it, what to do in assessments. So hopefully everybody can see that, and I hope y'all can ask some questions and get you on the right track if you have anybody. We didn't get any clearance. I guess it's not safe. I saw your messages as y'all were talking, so y'all got me on that one. I apologize for not paying attention. Um, so here we're going to talk about it again. Is we're going to talk about a cardiac tamponade, rib fractures, what is a flail chest, and a Komodo chorus. Huh. We'll figure out what that is too, so we all can be on the same page. All right. So here's some statistics that pretty. Again, these aren't up to date. I didn't have time to update the slide, but they're saying more than 70,000 people with chest traumas visits the EDs every year, and 18,000 people die of it each year. Let me go back and save my notes. Such injuries can involve the heart, the lung, and the great blood vessels. They may become a result of a blunt trauma, penetrating trauma, or both. So now we know what we're going to be looking at. EMTs must treat any injuries that interfere with the body's mechanism of normal breathing without delay. I don't know how many times we're going to say that over and over and over. Fix the ABCs, fix your initial bleeding, and stop the bleeding to begin with, and roll on. Air may collect in the chest to prevent the lungs from expanding. So we talk about our pneumos. You may collect bleeding. Um, the chest cavity can hold a pretty good bit of blood, so you're not obviously going to see that because it's going to be inside the cavity. Jesus, I'm trying, guys. I'm trying. So on your assessments, vital signs will should be able to tell you compensating versus blood loss, gain, and all that. So be cautious. Make sure you do full assessments, head to toe. Something catches your eye, maybe the shortness of breath, maybe the labored breathing. If you're having to bag them, why is it getting a little bit hard to bag them versus normal respirations is fine. So I want you to remember the difference between ventilation and oxygenation. There is a big difference. Ventilation is the body's ability to move air in and out of chest and lungs. So the body is ventilating. So oxygenation is the process of delivering oxygen to the blood by diffusion from the alveoli following inhalation into the lungs. Now, injuries affecting the patient's ventilation or oxygenation are serious because you're going to mess up the breathing. I mean, it's going to be life threatening, but now you've created an issue between the ventilation and oxygenation that the body does itself that's now not allowing oxygenation to move on, to move forth, continue the process, and be merry. Stand by. Getting text messages out the wazoo for some odd reason, and I don't know why. All right, so here's a pretty little picture. We talked about this before. We talked about the thoracic sac. That's inside the muscles and the bones of the sternum there. Unique features such as the striate or the skeletal. The muscles allow for ventilation. We talk, here, this is the diaphragm going up and down, allows the lungs to contract and expand. You have your intercostal muscles between all the ribs. So are going to be up in here. Some of us can see ours and some of us can't. Not yet developed. So the intercostal muscles are not always going to be developed in children. So when we call it a belly breathing, you're going to notice the seesaw method. Belly comes out, chest goes in, chest goes out, belly goes in. So it's called, they call them belly breathing, but it looks like a seesaw, up and down, up and down. And that's continuous because they're using their accessory muscles because they don't really, their body hasn't had enough time to learn what to do with these muscles and how to function and where to move. And so they just go back and forth in here. I'm trying to see what they want me to say. I don't know. It's very confusing on these notes here. All right, so the neurovascular bundle. So there's a network of nerves, arteries, and veins lying very closely along the inferior and slightly posterior of the lower margin of each rib. And I'm going to show you on the next one, so don't feel like you're trying to figure out what the hell's Wally trying to say. Just hang on. Pictures will help. This can be a source of significant bleeding if it's bled into the pleural space. So remember, there's very bits of blood that can go everywhere, and then once it starts pooling, you're going to have a lot of blood. The visceral pleura covers the lungs, and then a small amount of pleural fluid between the peritoneal and visceral pleura allows the lungs to move freely against the inner. Stand by. Look right there. That's the easiest way. I don't know what they're trying to do this to tell you. All right, right here, you're going to have basically this is surfactant that's up in here that keeps the lungs from sticking to the chest wall. So there you go. All this, the purple spot, is the pleura that the lungs have the room to expand. Okay, so here's your cartilage, your costal cartilage. You have veins that run on top of them. We'll show it again. There's your diaphragm pretty high. That's your xiphoid process right there in the center. Heart's hidden behind the lung. So when you take a deep breath, this entire pleural space is what we're referring to there. So that's part of the sac that they're referring to. So here's your intercostal space. If you'll see on the between each rib is what they're calling intercostal space. All right. Did the picture? I hope the picture helped out a little bit because I was reading that to myself and I was like, I don't get it. It's not working. So just remember, this is what they're calling the thoracic cage. Lungs, heart, liver, kidneys, all that stuff is right there basically wrapped up in the cage of the ribs. Okay? So now you kind of have a little bit better idea. So we're going to talk about the medium sternum. It contains the heart, great vessels, esophagus, and the trachea. Let's see here. So the location is where the thoracic artery dissection can occur. A severing of the aorta can occur when the body is exposed for traumatic forces. And let me tell you, the only way to save anybody that has a dissecting aortic, maybe I confused myself. So if they have a dissecting aortic aneurysm, you ain't fixing it. No ifs, ands, and buts about it. They're gonna die right there, and they will tell you, I feel like there was a tear in my chest. You move them any bit, a bump, bounce, move, they're going to die in front of you. Most of the one I've dealt with two in my life, both of them died a few minutes away from the hospital, and it was by no means of what we were doing. It was just that we were hauling butt, but we were driving as fast and smooth as possible. So, the intercostal muscles between the ribs, like we showed y'all. Um, it's between the ribs contract during inhalation, so they get smaller. The diaphragm contracts or flattens out at the same time, so it's increasing space for the lungs to go. The inner thoracic pressure inside the chest decreases, creating a negative pressure differential. So the pressure's going down, which is allowing the lungs to expand to their full width. When the pressure builds up, the lungs shrink, and that's exhalation. So the brain does not have to think about that, and it's a process that's automatically done. So air enters the lungs through the nose and the mouth. The intercostal muscles and the diaphragm relax during exhalation, allowing the air to be exhaled. The body should not have to work to breathe when in the resting state. So you're not burning energy when you're trying to breathe as you rest, is what they're trying to tell you. 2 seconds. Let me take my boots off. All right. Here's another picture. I don't know why this one's dark. I have tried all day long to figure out, why it's dark. So I can't lie to you. So as you see here, this is where the inflated lung is up and breathing, and then when it deflates, the diaphragm's big and the lungs are small. Now your lungs ain't gonna be that small, so that's not the best picture in the world, because I don't really understand it, and I know what they're trying to say. So, all right, here, a patient whose spinal cord is injured below the C5, so C5 is in the neck, right in here, may lose the power to move intercostal muscles. So, breathing is going to be the issue here. The diaphragm still should contract, and the patient still will be able to breathe, but the pharynx nerve remains intact. Patients with a spinal cord injury at C3 or above can lose the ability to breathe. Even though I told you, C4 and 5 keeps the diaphragm alive, because this entire process back in here is what allows you to function and breathe because of where the nerve is in the body. So if you have an injury here, this is where they're telling you it's going to go, is paralysis set up through here, okay? So that's kind of the picture behind that. All right, so we're going to go deep into this one. So the minute volume or minute ventilation is the amount of air moved through the lungs in 1 minute. It is calculated by multiplying the normal tidal volume by a patient's respiratory rate. Patients with decreased tidal volume will have an increased respiratory rate. All right, so here we go. Here we go again. A 1,000 to 1,500 milliliter bag valve mask might overinflate the lungs, which we know that, causing gastric distension and impaired lung impaired lung functions. Overventilation can increase the thoracic pressure, reducing the cardiac output and potentially worsening chest injuries such as a pneumothorax. Additionally, rapid respirations can cause acid-base imbalances and blood gas imbalance. All right, So let's back all that up. I don't know who is going to try to figure out the minute volume and tidal volume in the field. It's not important to fill it out to treat a patient. Yes, you need to know how to get it, but it's not going to affect anything until you becoming a paramedic or a critical care medic, where you're having to figure these out and put them on a vent in the field. Okay, so what we're going to talk about now is the 1,000 to 1,500 milliliter bag valve mask. That's why when I told y'all before, don't overventilate, because the pressure change that you're creating is also throwing up acids. You're throwing up the blood gases imbalance. You're overventilating them, so their blood cells are full of oxygen, and now they can't get rid of it. So even when you put a tube down and you start breathing normal for them, they ain't got no way to get rid of oxygen. So when you go to tube somebody, it's very just breathe for them, 30 to 2, rock on, do your respirations and bags like normal, because it doesn't benefit over ventilating a patient with a bag. Make sure your bag is properly sized to the size of your patient. Don't be trying to use a ped on an adult, because it's just not going to work. All right. So chest injuries. So there's two basic types of chest injuries. You'll have your open and your closed, and they're generally caused by blunt force trauma. I'm just gonna assume this was maybe by a car seat. I mean a seat belt. If anybody wants to guess differently, I'm not 110% sure, but it looks like a very good seatbelt burn. Could be a belt. Hell, I don't know, but it's not a really good picture either. All right. So closed injuries. So they're going to often cause significant contusions in cardiac muscles, which we're going to call that a cardiac contusion. A lung tissue issue is a pulmonary contusion. So you can have damage to the lungs because of a blunt injury, and they're going to give you a pulmonary contusion. If the heart is damaged at all, it may not be able to refill with blood, or blood may not be able to pump enough force out of the heart, because there may be a hole or some valve is damaged. Lung tissue bruising can result in exponential loss of surface area, and that leads to decreased oxygen and carbon dioxide exchange. So if you get struck by something, whatever, and you have damage to the ribs, your minute volume is going to go down because you're not able to breathe sufficiently. Ooh. In which we know rib fractures can lacerate the lung tissues. It's going to create more damage, and you're going to potentially have a pneumothorax, but they're going to potentially lead into hypovolemic shock. So you got to be careful and pay attention on if there's a flail chest, or a blunt force trauma injury to one side versus the other side. All right. And an open chest injury is an object, let's say a knife, bullet, some metal, maybe even the rib, penetrates into the chest wall. Okay. So such injuries cause instant damage, but symptoms do develop over time. It's not going to be instantly. Maybe with a gun or a knife or something like that. An impaled object remains, as long as the impaled object remains in place, do not attempt to remove the object. All right. Stabilize it, transport it in the same place that you found it. And that may be including the hole in the puncture vessel. Removing it's going to create more bleeding. All right. And then when you go to remove it, you may also cause more damage. It may be damaged by removing. You're going to allow a big gush of air to go in, or they're going to start bleeding. Now the lung or the cavity is going to fill up with blood. It all depends. So blunt trauma to the chest may fracture the ribs, the sternum, and the chest walls. bruise to the lungs and heart, and even damage to the aorta. That's very hard. That's a lot of force to damage the aorta. Now, you can damage and die from it, but be very cautious. Almost 1/3 of people are killed immediately in car crashes die as a result of a ruptured aorta. So they look perfectly fine, but you're like, wow, then why did this happen? Maybe they had a rapid injury to the heart. Trying to read group messages, sorry. Vital organs can be torn, which we know that. It's causing internal life-threatening bleeding from the vital organs being torn right there. Let's see here. Damage to the aorta. We talked about that a while ago. A dissecting aortic aneurysm. Very, very, very dangerous. Happens unfortunately more than what we should probably see in life. All right. So signs and symptoms of chest injuries. Going to have pain at the site. Pain location at the site of the injury that is aggravated or increased by breathing. It's irritation or damage to the pleural surfaces causes a sharp or sticking pain with each breath. So some people that's had pleurisy talks about that. That's kind of the same pains, and they'll call it a pleuritic pain because it only hurts when you breathe, and it's like, oh, oh, it hurts. And some of you that's had pneumonia and or worse respiratory issues, you know what I'm talking about. When it hurts to breathe, you know you sick. Any penetrating injury to the chest is obviously a sign and symptoms of it. I'm not real sure how that wouldn't have been obvious. Dyspnea, which we know that one or two word dyspnea is the difficulty breathing or the shortness of breath. This can be caused by airway obstruction, damage to the chest wall, improper chest expansion, or lung compression. You got to provide high flow ventilation is required during transportation with a chest injury because we already know that they're not getting sufficient oxygen to be able to support life and oxygen or carbon dioxide exchange. Okay, so we need to pump them full as much O2 as we can, and you may have to assist ventilations with them. We'll talk about hematopoiesis. That's right. So you have either spitting up, coughing up blood. You can have uh, some pinky froth with it also. That could be lung tissues that they're coughing up. This definitely indicates that there's been chest damage to the chest, to the lung, or the air passage, because now that blood's got to go somewhere. And when they cough it up, if it looks real bubbly, you know that that's definitely a sign of airway trouble. So failure or one of let's see here. Failure of one or both sides of the chest to expand normally with inspiration, and it's very obvious when you see that. Rapid, weak pulse and low blood pressure. It's principal signs of hypovolemic shock. Don't forget that. Signs of hypovolemic shock are rapid, weak pulse, and low blood pressure. All that can result from an extensive bleeding or some other lacerations within the chest wall. Cyanosis around the lips or fingernails, well, that's when their fingertips and their lips turn blue. That's 100% sign of inadequate breathing. Immediate ventilation and oxygenation are required, and I do mean high flow O2 is required. And I don't really want to say mandatory because it depends on your company's procedures, but you might as well say if you don't provide high flow O2 to them, your patient will die and will die on you on the way that you're transporting. I promise you it's going to happen. Patients with chest wall injuries often have tachypnea, which is because they're trying to get enough air to function. When they don't have enough air, they can't make things work, and that's what gets them. The patient may not actually be moving air due to the chest wall is not It's not expanding and contraction enough for them to get oxygen to breathe. That's why they continuously do it. When you listen to the lungs, you want to listen in multiple places. A couple places on the front, upper and lower lobes of the lungs. You want to listen to a couple of upper and lower places of the back to make sure that you hear respirations coming in and out. If you don't, ask them, why are you having trouble? Like, are you having trouble breathing? I had a lady that was an old nurse. One time I was listening to her, and I just did not hear any breath sounds on the right hand side. And my face showed it that something was wrong. I checked in different places. Finally, I was like, ma'am, you having any trouble breathing? Nope. Why you say that? So then I broke down and told her that I just can't hear breath sounds on the right side. Well, she starts giggling. Well, I didn't think it was funny. Maybe she did because she can't breathe. She had her right lung had to be removed, which you could have seen the scar if you'd have lifted the shirt some and seen, but didn't know that without doing a full assessment. I would not have found that out. All right. So we know the scene size ups are always the same. Check your scene safety. If it's a crime scene, don't disturb the evidence if possible. Always request law enforcement if you feel like you're going into an assault, stabbing, gunshot wound. If you just don't feel comfortable, request them and wait till they get there. I'm going to read this to you. This is funny. If needed, call for electrical, utility, fire department, or advanced life support units early. I'm not real sure what the power company is going to do for me, but okay. And then make sure you have all of your PPE on. If you don't have all your PPE on, you're being negligent to yourself and potentially can danger yourself because of what you're touching, what you're exposing yourself to can produce some problems. I want to know what the MOI is. What caused this injury and how bad was it for me to have to be here? And what made it so bad? Chest injuries are common in motor vehicle crashes, falls, industrial accidents, and assaults. We know that they're common because we've seen them over time. Heavy machineries, slip, trips, and falls, even in the workplace, can cause them. You can get MVC's reason why is because the body can take damage pretty easy and be beat up and recover. But when you're going 75 miles an hour and you make a sudden stop, so are your internal organs. They're making the same speed and they're trying to make a complete stop and they can't. Those hollow organs will bounce back and forth inside your internals, your guts, and they can damage themselves. You want to always say, hey, how many people do I have? How many is going to the hospital? Oh my God, that guy looked horrible. I need extra units. Um, and transport them to the most appropriate facility once you start figuring that out. Always consider the spinal immobilization. We went over the KED. Matter of fact, we used stair chair last night several times trying to get my patients out of here. It's a use the tools that you have to better the job. If you always work hard, you're going to hate life. You're always going to put them on a Stokes basket and carry them up and down stairs when you got a stair chair in the truck. You just don't know how to use it. Probably a bad idea. We'll go over primary assessment. We'll take a break. So the primary assessment, we know form a general impression from the front door. See what's going on. What is there and how do they look? Any life-threatening hemorrhaging, stop it, fix it, make sure it's done. Are they able to breathe? Can they talk to me? If they talk to me, then I can tell you what their AFPU is, and if anybody remembers what AFPU is, I hope y'all do. DCAT, BTLS, everything. You can start semi-answering your sample questions as you're walking up to them, but your general impression is going to be what lasts. Obvious injuries, if you see it, fix it, stop it, bleed it. If it is a life-threatening injury, fix it. If it's just down that there's cyanosis and they having trouble breathing, Wait, y'all, we hope you know you can fix that. You carry oxygen and probably a green bag or a little blue tote bag that is the answer for short-term care. Put them on oxygen, transport them to the hospital. Easy, done, next. So make sure your treatment is good. You want to listen for chest rise and fall, not only on one side but both sides, just to make sure that you haven't missed an injury. It may not be a complaint to them, but it's good after a very bad MVC to do a complete assessment down both sides, left, right, front, and back. Make sure that the patient doesn't have something that they just didn't know about. If you happen to see them using their accessory muscles, you know that they having trouble breathing. So fix it. Overall appearance. What do they look like? And just be like, how sick is this patient? You're gonna perform that all in your head, and then when you're like, oh, they not so good, and you want them out of here, well, why are you waiting around? Or do you have to wait on ALS care to get there when you should have been like, maybe I should have called them like 10 minutes ago so they could be here, but now I got to wait 30 minutes because the closest unit just called a call. So think about that as you're responding and making your impressions. Airways, address life threatenings begins with the airway. We know that. Ensure that the patient has a clear and patent airway. Is the breathing normal, labored, distressed? Is it irregular? You need to know the rate, rhythm, and type. Consider early spinal stabilization if you suspect any sort of trauma. Do you see JVD? If you don't know what JVD is, I highly suggest you look it up because it's jugular vein distension. You'll notice on the sides of the neck that they're sticking out, and it looks like just this big bulge of their carotid, and you'll be able to see. Signs of pressure. Now you may have a cardiac tamponade. Is the heart in distress? Uh, you, if you have a cardiac tamponade, it may be a result of a tension pneumo. Some agencies may allow you to do a needle decompression. They may only allow that to be an advanced or a paramedic skill. And it may result from an injury to the heart that's bleeding into the pericardium or created a pericardial tamponade. So there's so much going on the inside of the chest. It's scary at the same time. It's like, oh, I gotta fix this, and you get the pucker factor. Always do decap BTLS anytime you're assessing the body, a limb, head to toe, forward to back. It's tried and true, and it works. So changing the system ultimately will be the problem because you're trying to create a cog in the wheel that it's already been done and it's working. So just continue the process. Um, let's see here. Look, listen, and feel. It's the best way to do that. Um, maybe in let's see, unequal expansion may be related to an injury of the nerves controlling those muscles. So you may be delayed, or they may not breathe at all because that chest slash back injury has pinched a nerve or cut that nerve in half. And now you're going to have to supply oxygen. You're going to have to support their ventilations. Uh, you may even provide positive pressure ventilations, and that's just by some supplemental O2. Um, let's see here. Do not use this type of ventilation for. So you don't want to use positive pressure ventilation if you suspect a pneumothorax because you're increasing the pressure. So remember that. If you suspect that at all, you want low flow O2 so it won't create a worse problem. Whew, sorry, folks. I don't. It's every time. Y'all used to it by now. Always listen to their respirations. I do it pretty regular. That I listen to them. I want to say, okay, be quiet, take some slow deep breaths. Let me listen to you. Okay, ma'am or sir, will you lean forward? Let me listen to you here. All right, thank you so much. Hang on 1 second, y'all. Hey guys, y'all take 10 minutes. I'll see y'all back in 10 minutes. All right, let's see if we can get to the rest of this. All right, so I don't remember what I said. I was on a tantrum. Sorry. So we're going to continue to auscultate breath sounds every time even throughout the ventilation process. If we're bagging, even though we're using a face shield, a face mask for this for the bag, still want to get your partner or a rider to continue bagging while you listen to breath sounds. Um, be on alert for decreased oxygen saturations. Make sure you've got your tools and equipment on properly. If you notice sats have dropped for any particular reason, make sure the the O2 monitor, the O2 sat is on correctly. That can lead to hypoxia if not done correctly. Be on alert for signs of impeding tension pneumothorax, like increasingly poor complacency during ventilation. So if it's hard to bag and you notice you're like, man, I'm really having to force this every time I bag for him, there may be an underlying cause. Pay attention to that and don't just get blindsided later down the road when you don't recognize something. Assess the pulse and determine whether it is present or adequate. Well, I mean, it's either there or now you're fixing to code somebody instead of worrying about chest injuries. Just saying. I mean, that may be wrong, but um, if the pulse is too fast or too slow, or if the skin is pale and they look like they're going in cardiac arrest because it's cool and clammy, consider the patient to be in shock. Or it's too late now, and you want to address all the life-threatening bleeding immediately. Control the sternal bleeding using direct pressure, bulky trauma dressing, and last resort is a tourniquet. Now I know we keep saying tourniquet. A lot of things have changed over time. Um, Time and place, we've increased things, made things a whole lot better. Initially, when they came out, tourniquets were always 2 inches above the wound. That is not so true no more. Not saying that it won't work, but anytime you apply a tourniquet, you want to do it high and tight. It's the easiest acronym to remember. It's high and tight because if it's upper arm, you don't want to do 2 inches. And I can promise you the reason why things have changed is because during blast injuries during the war, they've noticed that just because it's 2 inches above, there's nothing to bite on. Maybe if it was blown off or, the eye got cut off or whatever else, there's nothing for that tourniquet to take a bite on to be able to control the bleeding. So that's the reason why the uh, TCCC and PHTLS and ITLS did some studies and all that fun stuff and made it to where and realized that it is high and tight saves lives. So anytime you apply a tourniquet, make sure it's high and tight. Just saying that y'all may hear that again at boot camp. All right, so we transport or we go into the right facility. Do we need to delay and stay on scene and stay in play, or is this going to be if we stay too long, we're reducing the chances of survival? So don't just stick around and play. Make sure you take this patient to the most appropriate facility. On your in your book 29-1, you will notice this chart and where's my notes? So this is the list of the deadly dozen chest injuries. So these are the most deadly ones that they have come up with through Jones and Bartlett that have made sense to them, made important. All of those are life-threatening if not addressed and corrected. So your history taking. When you do a history, we've gone over this time and time and time and time again. Do a fully thorough history. Um, if you have time, investigate what the MOI was. You want to identify all the signs and symptoms. Take pictures if you can. Some facilities will want to see pictures, or it helps over time with the hospital get an understanding of what injuries they do have versus what they're going to find at a later date. Sample history. If you can get it, get it. If there's nobody there to get it from, just got to go with what you got, bruh. It's like playing Jeopardy. Sometimes you don't know the answer, but you make it up and you lose money. Hopefully, we don't lose lives. We just try to make sure we treat them the best we can. Physical examination. We want to isolate the injuries. We do what's best for our patient. Focus on the body region that is affected, but don't get blindsided by the other potential injuries that the body's going to have. Let's see. Ensure wounds are identified and bleeding is controlled. Location and extent of the injury is important. Don't, like I said, don't just get blindsided because you're like, oh my God, there's something impaled in the dude's arm. Well, it's not a life-threatening injury, so let's just get to it when we get there. Change in respirations is very, very important because that is a life-threatening issue. So be very cautious for that. If they say they're having trouble breathing, what are we gonna do? Give them oxygen. It's cheap. It's easy. Let's give it. Um, so here we're going to use DCAT BTLS for every part of the body, for the injuries, for the particular injury. If it's an impalement, you have deformities, contusions, abrasions, penetrations, burns, tenderness, laceration, swelling. So yes, we would have a penetration, and you're probably going to have swelling and bleeding, all this fun stuff that goes along with it. Let's treat it. Let's take care of it. Let's use our jobs and our skills that we've learned through this course. So we know vital signs. They should be taken every 5 minutes for a critical. Increased work of breathing can be identified by the use of accessory muscles. So if you notice your patient starts to have use of accessory muscles and the chest and neck and the face are having issues, and you notice like, why are they look so mad when they breathe? Well, because they're struggling. Give them oxygen. Let's see here. If the myocardium becomes starved for oxygen and the body can no longer keep up with the demands, then the brain starts to become deprived of oxygen and overloaded with carbon dioxide and all the other crap that's not getting changed out because you don't have proper perfusion. So if we can keep the perfusion going, the better off our patient's going to be in the long run. Let's give them oxygen, high flow oxygen. Reassessments, we're going to continue that. Once you get done with your primary initial assessment, once you go from head to toe, fix what you come across, fix what you find, your life-threatening injuries, then go back to your reassessment. If reassessate your ABCs, is the bleeding control that we stopped initially, is that wound or tourniquet or pressure dressing, is that working? And document what's happened. Well, you're not going to stop to document, but you will eventually. Then we're going to go back and we're going to reassess all of our interventions. If I applied X to his right arm, is it working? Is it got any better? Do I need to do anything else? So again, that's the best thing that we can do right there. Let's see, interventions. Patients with signs of hyperperfusion, you want to provide aggressive treatment for shock, so we don't want to delay that. Provide rapid transport. Do not delay the transport on scene to complete some crappy non-life-threatening injury. Just because you want to get to the hospital and be like, I've got my report done, I've got everything done, we're good to go. No. What you did is you were negligent and tried to make you look good before you got there. Just take them to the fastest hospital as you can. It's okay if you don't really know what to do, but just make sure you don't cause any more harm, but learn from your mistakes and ask and get educated. If you don't know what's going on or you feel uncomfortable, educate. I have reached out to both medevac pilots or paramedics that came out here to pick up my 2 patients, and I've called in and say, hey, when you get time, call me. I would like for you to tell me if there's anything that I can do and or do differently. That's just for me to educate myself better and go from there. I'm not asking to say, what did I do wrong? Because I know I did everything that I could, but what can I improve on things to make me a better paramedic? All right, so a pneumothorax. What a pneumothorax is it's a collapsed lung. That's really what it is. So it describes an accumulation of air in the pleural space. Air enters through the a hole in the chest wall or on the surface of the lung. The patient attempts to breathe, causing the lung on that side to collapse. So let's say it's on the right side, and they take a deep breath. It's like putting a hole in a balloon. She ain't gonna work no more. It ain't gonna work. Got to go. So blood passing through the collapsed portion of the lung, it's not gonna be oxygenated. It's just gonna be dirty. We gotta fix that. Breath sounds on the affected side will be noted to be differently and or deficient. If the lung has collapsed past the 30 to 40% range, you will hear diminished breath sounds. I don't expect you to remember that on what's the percentage of no. But just understand you're not going to hear them until that lung has 30 to 40% up to anywhere between that, and then you're going to start notice diminished breath sounds. You're going to potentially notice absent of breath sounds on that potential side. It may be because of the pneumothorax. You may hear a sucking sound on inhalation, not coming from the patient, it's coming from the wound, and the sound of rushing air on exhalation. That's going to tell you that that the chest wall has been penetrated. Now, you're not going to hear. It's very minute, it's very dull, but you will hear sucking. Here's another bad picture. Don't know why it's this way, but we're going to say it's tired too. So that's the collapsed lung. If you'll notice the wound site right here is the circle. It's the holes, the penetration, whatever else. But now this lung has become collapsed because this lung is taking a deep breath. It is extended all the way out that it can. And now this one's not going to work. And it has lost the surfactant through here, and the pressure change now is filling up with air. It's causing pressure on this lung, this side right here on the right side to be deficient. We got to fix that. So it's an open chest wound, which we talked about again. So after clearing and maintaining the patient's airway, and you give them O2, some of these wounds may be rapidly sealed with an occlusive dressing, and that could fix it. All right. The dressing prevents air from being sucked into the chest through that particular area. And there's two types of occlusive dressings. You have your commercial vented occlusive dressing, and then you have an improvised occlusive dressing. So an improvised is you take some petroleum jelly, you take some, which is Vaseline, however you want to look at it, some aluminum foil, and some plastic, and or, doesn't really matter. So a flutter valve is a one-way valve that allows air to leave the chest cavity but not return. So if I'm going to do it, let's look at this picture right here. All right. I'm going to do some very bad drawing. I want y'all to know that, okay? All right. So if I want to fix this spot right here, can everybody see that? Just my marker? I'm sorry, I just couldn't work. Chase, we missed you, bro. We have missed you. And now it's time for you to talk since you came in late. I'm just speaking for you. All right. Everybody see me moving my little cursor right here? We good? All right. Bueller. All right. Good deal. So I'm going to make my own three-sided dressing. Take a piece of tape, tinfoil, plastic. I'm going to lay it right there. Okay. So now, once that's laid down, I don't know how to change colors. Hang on. Uh-oh. I'm sorry, this thing's... All right, so on this side, I'm just gonna make it bigger. This side I'm gonna tape. All right. This side I'm gonna tape. And this side I'm gonna tape. I'm gonna leave the bottom open, okay? Because it's easier if something comes here, if I left the top open, stuff can fall in and potentially get inside the lung. But this piece of plastic sometimes will bubble up, and you'll have air pockets building in here. You can just burp it, which you just put your hand on there, and you push down a little bit and it burps through the air down through here, okay? So that is right there, all right? So that's a three-sided occlusive dressing. It's homegrown, simple, done in a couple of seconds, all right? Yes, so you do leave one side open. Now, if I can figure how to get this off. All right, so now that is a homemade, off the truck, Chris Wally special. We're going to take him to the hospital. If you don't have a chest seal, so a chest seal is a circular piece of product. I don't know how you want to put it. It's thin, it's clear, you can see through it. And it has, so if everybody remembers the old days where you had your whoopee cushions, you know what I'm talking about? Or am I showing my age? Please don't make me show my age. All right, so on the whoopee cushion, if y'all remember, you had, I got to draw that, and I'll tell you what that is. So here's our whoopee cushion right here. And one side, you had the little valve right there that made the fart noise, right? Y'all got me? So this is the same exact type of principle. So it let air out, but you had to squeeze and open down here to let air in, if y'all remember that right. So on a commercial chest seal, all this right here is closed. It sticks to the chest. And there is a little valve that sticks. Well, take that circle out right there. There's a little valve that sits down in here, okay? And it lets air out, and it'll sound, it sounds like it's Putin, but you cannot let air back in. Y'all follow me? So you can push air out of it, but if air tries to come back in, it's not going to come back in through that valve. This is the same principle as the whoopee cushion, except this is a manufactured chest seal. Any questions on that? Because I know my drawing looks like poo. Anybody? Did I lose anybody on that? Maybe not. All right. So, all right, repeat it. Gotcha. Let me get my marker back out. Uh-oh. All right. So, if I'm going to make one on the fly, what is the question again? Again, sorry, it's been a long day. All right. So, I just explained the homemade chest seal versus the manufactured chest seal. A homemade chest seal is a four-sided piece of plastic bag. You take off, like if this is a sandwich bag, I want to take off one side of it. I'm going to tape three sides of it down to the chest. I'm going to leave it clear so I can see here. And then when this fills up with air, I'm going to take my hand and push down on it, and the air is going to escape. But you're going to have Vaseline on the corners here. And the reason why the Vaseline is because it sticks to the skin. That's it. That's your flapper valve, your pooter valve, whatever you want to call this little thing right here. That's how you get the air. It's a one-way chest seal. It's homemade, it's quick, simple, easy to go. Now, if I'm going to go buy me a manufactured chest seal, it is a circular one. Has a little, sometimes you'll see some like 4x4 material along the inside right in here. And then you will again have the manufactured valve that is right here, sits right in the center, and only lets air out of here. You cannot bring air in. Bringing air in stops at the valve, nothing comes in. I know it makes no sense. If you will Google what a chest seal is, you'll be good. Square, if you want a decent seal, a three-sided occlusive dressing. So on the seals, if you buy this like an Osherman chest seal, it's gonna tape everything down. It sits flat. It's just like a clear Band-Aid. with the valve. Now, homemade, I'm going to have a 3-sided, it's actually going to be all 4-sided, but I am going to tape down 3 sides of it. It's a 3-sided occlusive dressing. How's that sound? Did I lose anybody?
Nope.
Good. I like to hear it. I'm trying. We are trying to have a good party. Let me get back.
Hey, as long as it's better than the one I had earlier.
Well, bro, I've been beat. I get it. I'm ready to go to bed. I've been up for almost 48 hours, so. Whew. All right. So now we're gonna move on. Well, now I can't click on. Oh, hang on. I gotta get my pointer back. All right. So a simple pneumo. So this does not result in major changes in a patient's cardiac, but it does commonly result from blunt trauma. You will have decreased breath sounds associated with significant lung collapse. So remember that just with a simple blunt force trauma, you will notice decreased breath sounds. All right. So you'll have dyspnea. You'll notice that they're breathing rapidly, and it could go from 22 to 24 to 26 times a minute because they're like, I can't take some breath. I feel like I'm having trouble breathing. So, and their respiratory rate will increase. So they may start using those accessory muscles. They may be in the tripod position because they're trying to take the weight off their chest. You will notice that their oxygen saturations drop. You potentially sometimes can notice a crackling sensation if you palpate their skin. That'll be like a snap, crackle, pop. It's what it sounds like. It feels like the little clear packing bags. And then if it's late, that's a late finding. Oh, let me get that out the way. You're gonna decrease breath sounds on the injured side. They're gonna be very lethargic. They're gonna be cyanotic, and the pneumothorax can often become worse or deteriorate into a pneumothorax, which is going to be bleeding. You'll have all sorts of other stuff. The best thing that we can do in the field is high flow O2, pay attention to their pulse ox, because that's going to notice and tell us a big difference. And you can just treat any underlying causes of the injury. They start having trouble breathing. Well, you can fix that. Now it feels like they're struggling to breathe. Bag them. You help breathe for them. That's the best things that we can do. All right. So a tension pneumo. This results from an ongoing air accumulation into the pleural space. There's a picture coming up that's going to explain it a lot. I hope y'all will get it. All right. This air gradually increases pressure in the chest. It causes a complete collapse of the unaffected lung. That's pretty serious. We know that. Mid stadium is the central part of the chest, the larynx. You'll have a medial shift is going to be pushed to the opposite pleural cavity. Blood cannot return through the vena cava of the heart because there's so much pressure in there. The cardiac output is going to be decreased, and this does lead to shock, a pneumothorax. All right. Ultimately, if it's not treated, they're going to die. Tension pneumothorax is very common. It's caused by blunt force, which is going to crack a rib, or can go in there and lacerate some of the lung or the bronchus. Some of the signs that you're going to see: chest pains. It's going to be painful. Tachycardia, increased heart rate, and you'll have some marked mild to moderate respiratory distress. Ultimately, it'll get bad. You'll notice some breath sounds are going to be absent. You'll have hypotension, and hypotension means low blood pressure. They're going to start acting a little crazy, maybe confused. Their mental status is going to change. You will have positive JVD. They're going to start getting the blue lips, the blue fingers, because they're cyanotic. Now you're going to notice the trachea is going to start deviating. Best thing you can do is supply high flow O2 and call for ALS. Needle decompression is what's needed, and that has to be done by ALS provider. All right. So now we have our wound site. This is on the outside of the skin. Here it is on the lung. All this area is filling up with air. The lung is collapsed. We know that because now there's the hole right there. So here's your bulging in the intercostal space. See how it's starting to poke out some? Diaphragm's contract. It's relaxed because it's contracted because you're taking a deep breath. Now you see why the heart cannot pump blood out, because it's pushing over. Everything's starting to shift. You notice if this was a straight line, I'm sorry, I'm drawing on the wrong goddamn screen. So now you can't come right here. Blood's not going back out. If I could draw a straight line from the larynx, air pipe, you notice how it's starting to shift. Everything's moving over to the left side of the body. Your vena cava is starting to get blocked. So now we're starting to have some issues, okay? So speaking of respiratory, can I ask a few questions? Please, that's fine with me. You're gonna turn your mic on, that'd be fine.
Okay, so I know we kind of like, open discussion in class. So with me being on the truck, I had a few questions asked, everyone in the class. Basically, the first question would be, if you have a patient with COPD that is satin in the 80s to higher 80s, do you put them on oxygen or no?
Yes.
And this is for the class, not for you, Chris.
Oh, sorry, my bad. Then go ask the next one because I just spoke out loud.
Well, it depends. If they're on COPD and they have been clinically diagnosed, I don't know. I guess it's different in the South. Like our protocol up here is if they have been clinically diagnosed with COPD and they're sat in the 80s, we don't put them on oxygen. Just because of the fact we don't want them to become oxygen dependent. And once that happens, then, you're just screwed. Another question is, does anybody know the easiest way to count respirations?
What is that? Tell me.
The easiest way to count respirations is 15 seconds. You count how many times they breathe in 15 seconds and multiply it by 4.
I like to say this is the quietest class I've ever taught because everybody ever speaks.
I can tell.
What's your next question?
If any more come to me, I'll let you know.
Okay. Travis, when you say you really don't agree with that, are you referring to putting COPD patients on air? All right. So I understand what you're saying, but the way that they teach you is you either count for 1 minute, you count for 15 seconds times 4, or 30 times 2. It's a baseline. Um, it's just a simple way to do it in a hurry.
Okay, so for instance, Travis, Tuesday I was on the truck with my FTO, and it was a basic transfer, nursing home to dialysis, or I'm sorry, nursing home to the hospital to wound care and back, or for MRI and back. We get her, she has ARES, which is acute respiratory distress syndrome. And when we first put her on the pulse ox, we did her blood pressure on. Her blood pressure was low. She was sat in mid 90. And basically, my FTO looked at me and said, she's sat in around 90. She also has, COPD clinically diagnosed. Should we put her on oxygen? No. You do not want a patient to become oxygen dependent. Once your patient becomes oxygen dependent, then it turns into they're always going to need oxygen after that. Even if it's 0.5 to 2 liters, they're still going to become oxygen dependent if on it too long. So, and I mean, it may be different because I know most of our protocols up here are different. Like up here, even our birds, it don't matter if it's serious enough, and even BLS, if they think it's serious enough to activate a bird up here.
How was that? Y'all get that one? Any other questions? Because I really like that. That helps. Um, I understand the protocols. I do get it. But again, I guess it's a personal thing. But I understand. Different areas, different strokes, different folks. So I'm not gonna argue with it. It's a good point. I understand it. And I see why they do it. It's just something I'm not used to. I could. Uh, okay.
I mean, it's basically, to the point that we're mainly IFT. We're trying to advance into more. But up here, EMS is a dying field altogether. It's even going as far as we're trying to pay people to go through EMS classes because nobody wants to be an EMS up here.
Oh, I get
Yeah, it's that bad. Like most of our medics are babysitters for basics, is what we call them, because our field supervisor is the only medic in the last 2 months that has pushed any kind of drugs.
Wow.
So, yeah. And it's just, the one we had today, he was the last one of the day. It was called in as an ALS transfer. He was ALS. Blood pressures ranged anywhere from 149 over 112 all the way up to 173 over 120. He was vomiting. He had black stool. He was vomiting up black coffee ground looking vomit. And he relapsed from alcoholism. Basically, he was sober, relapsed, started drinking again, started vomiting. So by the time we got him halfway to the nearest trauma center, he was complaining of belly pain, belly distension. Basically, it turned into, once we got to the hospital and they started assessing him, he had an upper GI bleed. And the previous hospital ER we transferred him out of did not even catch it.
That's why I finna have a GI bleed.
I get it. Some folks, I get, like I say, different strokes, different folks, man. I know. Why will it not let? All right. So now we're gonna talk about hemothorax. I appreciate you talking about that, man. I appreciate that. It helped out. I hope y'all got something from that. Um, so a hemothorax, that's just blood in the pleural space. That's all that is. Um, I don't know how to break it down anymore. So here we go. I I don't know what this is. Can you might tell? It looks like a tie-dyed organ. All right. So I just don't know why the picture is so dark. Anyway, your pleural space is the clear part. You have your wounds. I don't know if y'all can see the little hole, and then blood's going to pool to the bottom, which is what we know. All right. So you can most of the time, if there's a whole lot of blood, sometimes you'll see it come out, but it will go into the internal cavity of the body Depends on if there's something for it to flow all the way out. I've seen it both. I've done chest tubes, so chest tubes suck. Just gonna let you know. Hope nobody ever has to have them. They hurt. All right. So common signs and symptoms of shock with an obvious external bleeding or apparent reason for a shock state. You're going to have decreased breath sounds on the affected sides. So the lung that is compressed by the blood is where you're going to notice, all right? Bleeding cannot be controlled in the pre-hospital setting. It's just going to fill it up. That's just, you got to go. You're going to provide rapid transport to the nearest facility capable of performing surgery. If they can't do it, there's no sense in stopping. You may have to run them by air. Like we just found out, but it just depends on your local service, how they do it. A pneumothorax is the presence of both air and blood in the pleural space. So that being said, that's pretty bad. I mean, there's going to fill up with blood, and then now it's already collapsed. So now air is going to fill it up if you don't occlude the hole. We don't poke nothing in there, but we need to close it so it can function, and you got to do your job and recognize it. Cardiac tamponade. Cardiac tamponade is a pericardial tamponade. This occurs more commonly with penetrating chest trauma, although it can happen with a blunt trauma. So the protective membrane around the heart fills with blood first or fluid. The heart then cannot pump. Look, here's a picture. So the heart cannot pump any adequate amount of blood. So if you'll notice, that's a normal heart on your left. And then you have the cardiac tamponade on the right. It just can't function. She's done. She's tapping out saying, I'm through. I don't know what you want me to do, but I'm done. All right. So now we have, huh?
That's a quick question. So does anyone know what the procedure is called when they have to release the pressure from the muscle around the heart or the sac around the heart?
Yes. No, sorry. Just give them a minute. They'll respond.
That's called decompression.
Anyone else? All right, so the procedure that they do for that is called a pericardial centesis, which basically relieves the pressure of the fluid from around the sac of the heart.
If you happen to know somebody that's in a facility that has some stout, sometimes if you bring a patient in and they rush them straight to surgery, sometimes you may be able to watch that. It is pretty cool. Sometimes they'll allow you to sit in a room to where you can watch it, or scrub in, sit in the corner, and not say nothing. Uh, I've been able to watch a couple of surgeries that way. It's been pretty cool. So just because I recognize it and I was like, hey, you got any room left in the surgery? I want to watch this. So it never hurts to build friends in high places like that. So think about that if you start recognizing this and you're in a smaller area and you know some good people. So cardiac tamponade. So does anybody remember what the Beck's triad is? Or does anybody know? Hmm?
A pain in the butt is what it is.
Oh, yeah, it's very bad. So you're going to have both JVDs extended on either side of the neck. And you'll have narrowing pulse pressures and muffled heart sounds. That's your Beck's triad. It's late diagnosed in the field because everybody's like, whoa, what is that? I know that's not supposed to be there. What's the deal? So what you're going to, whoa, my bad. I don't know what happened here. So you'll notice some altered mental status because they just not functioning like they supposed to. The body is just like, hey, bro, something's wrong with me. I need you to fix it. Uh, it's not even Robin. That's not even a paramedic skill. Trying to do a pericardial tenthesis in the that you see that on the movies, but don't believe that. That is a surgeon or a cardiac surgeon's job and job only. It, it,
Not to be a pain in the butt, but in certain places, and like up here, certain places and certain departments in the north are actually allowing paramedics to do that in the field.
no, no, sir. That's hmm, that's scary because you can kill them in a heartbeat.
Oh
Uh,
yeah.
in the pre-hospital setting, really the only thing y'all can do, and we can do really, we can give them some ventilation, some positive pressure, get them some air, and high flow of fuel to the facility to get them out of there. Um, Robin says in the ER they do it. Yeah. Um, Not sure if you're saying RNs do it. Um, they may be specialized into it, but I know in the South it ain't happening around here. I can promise you. Uh, that's doctors just hanging on to their skills because they know they're losing things. Um, why is it not typing? Oh Lord, there we go. So rib fractures, yeah, those are serious. They're painful. I don't. Sometimes you can get the pneumohemo and pneumothorax out of them, but it's not as common. Slip, trip, and fall is not going to cause it. You may get a blunt force that takes a smack to the baseball bat to the rib that will cause it. You're going to get them more in blunt forces. Just because you cracked a rib or you broke a rib from maybe football, you're not going to create a puncture. And but anything's possible, so don't hold me to it. That's the reason why I was like, you'll never see it, because I don't say that shit. I just won't. Because it'll come back to bite me, and you're gonna be like, hey, remember when you said this, Chris? No, I don't. So that's the reason why I don't say never. Rib fractures. Basically, what's gonna happen is the patient is going to guard that particular. Hang on, we'll go right here. So the patient's gonna guard that particular area. Here's your break right here. This is going to be considered a flail segment because it's one or more ribs. Now, they're going to put their arm, they're going to put their hand, they're just going to hurt. So, what the easiest way that we can do it and fix it in the field for them to feel some sort of breathing is take a normal saline bag and lay it on their chest. And you can take two of them, tape them together, and just secure it to the chest. Some Curlex, some ace bandage or something like that, because you don't want to apply too much pressure, but you want to apply just enough pressure to where all the ribs are moving in accordingly. Because what's going to happen is these ribs will go out, the broken ones will go in, and vice versa on respiration. They're not comfortable. I've never broke one. I've taken care of multiple flail segments. Um, I've transported people with impaled pipe, tree limbs, arrows. So I've seen a good bit. I actually had a dude who had rebar all the way through, broke 6 ribs, and he secured the rebar as we transported. He held it. He's like, "Oh, this is not comfortable." I really know how to secure it, but he transported himself. Basically, I just drove. Not really. I was in the back with him. Biggest thing we can only do is just provide supplemental oxygen, give them, supportive care, stabilize it, continue to monitor for any other changes. Is anything else changing? What's going on? Do I need to do this? Do I need to do that? So pay attention to your patient. Treat your patient, not your monitor. Chase, does anyone remember how to determine if they have broken ribs?
And trust me, I'm gonna tell you right now. I've been on the truck for a couple of weeks now. my supervisor and my FTO. Treat your patient, not your monitor. Treat your patient, not your monitor, over and over and over again. So I promise it will be drilled into your head.
There you go. I'll tell you, one of my dudes last night, come in, his first initial heart rate was 265. Blood pressure was 255 over 148. I was like, well, I'm fixing to shock this dude, and we finna have a cardiac arrest. He's gonna die right here. Yes, what a shitty night. That's how my night started. But I fixed it. We got his blood pressure down. When he left, he was 126 over 97, and I didn't have to cardiovert him. I was kind of upset because I wanted to shock him, but he was being stingy. He wouldn't let me. Why? What was that?
Because nobody has answered that question yet. Remember one thing. You're always going to remember your assessments. DCAT, BTLS. You're also going to want to remember when it comes to other things like he was talking about with the altered mental status as your AFPU. You're either going to be 1, 2, 3, or 4. You ask them their birthday, if they know where they are, who the president is. That's how you determine their mental status. Of course, if they do have, it's listed if they have a history of Alzheimer's, dementia, anything like that, you already know that's your mental status. So those questions are kind of not going to be very pertinent or helpful in your determination.
But you can build off of one as that being a baseline for them. If they're, let's say you give them a GCS of 12. Well, if that's common, if that is their baseline, that's they're always a 12. Or if they're a 10, just because of other underlying issues, you can mark that in your report. That notice that patient is a GCS of 10, and that is common for them. So you can also note that as you're doing your assessment. Oh, come on, computer. Some other, well, we already talked about that. Whoops. All right, so some other chest injuries. You'll have your damage and bruising to the airway. You should always be suspecting a flailed chest with a patient and a pulmonary contusion. Always. Pre-hospital treatment, the best thing you can do is just provide oxygen. I don't know if you've noticed, that's what we do 90% of the time in this whole entire chest injury, is just give them oxygen and let's go. So you may have some sternal fractures, clavicle fractures. Clavicle, just so everybody knows, is the one that runs from your shoulder blades, the little bony parts that stick up. It's like you have a little cavity between there and your shoulder. However you want to go from there and label it. Sternum fractures, they're painful. They potentially can have some other underlying issues, and you have to figure out what else is going on just off of what you see. And just remember, don't get blindsided about what the initial injury is. Hold on, let me. All right. Clavicle fractures. I don't know about when it says be alert for pneumothorax. Okay, I mean, but always suspect, even though that there's a clavicle fracture, midline, where it says medial clavicle fractures, you potentially can have central area rib fractures too. So don't just isolate just because you're like, oh God, that looks broke right there. That's not supposed to be like that. Don't be blindsided. Continue your assessment. Listen for breath sounds. Decap BTLS the area. Put your hands on it and expose it. If you can't see it, you can't assess it. Be polite when I say that, and you think about it because you're probably giggling right now, but you got to be careful. You can't see it, you can't assess it. But if you see it, you need to also remember That's somebody's family, mother, daughter. Respect them and their privacy too. Okay. All right. So traumatic asphyxiation. So you notice the distended. Okay. So right in here, you'll notice the distended neck veins. See how thick and fat it is right in here, and there's uh, your cricoid is right in there. Cyanosis. If you can see some of the, you can't see. I can see it on my screen better. The blueness right in here, and then right in the eyes. See, this is called battle signs. You can't really see it right here. Raccoon eyes, battle signs. On my big screen, I can see it. There's bruising right in here, and what that is called is that is from a traumatic injury to the face or asphyxiation. See, it's probably what happened here is they hung themselves, or someone choked them. Not see whatever happened to him through the scars. We're kind of building our own story. Looks like there's a puncture there, maybe on this other side, but most likely something cut off his windpipe. Who knows? We'll change that one. It's kind of scary. Um, Traumatic asphyxiation, sudden severe compression of the chest. Let's say an unrestrained driver who hits the steering wheel suggests an underlying injury to the heart and possibility of pulmonary contusion. Monitor vital signs, transport appropriately. It's really all that they're going to tell us we can let you do. All right, so blunt force myocardial injury. That's when the heart is bruised, not because you all sad and blue and my heart's upset. No, that's not like it's really got a bruise. So blunt force may be an injury to a heart itself, but making it unable to maintain adequate blood pressure. So you may have a normal one, a low, super low, and then back to normal. So you're going to continually bounce back and forth because the heart is in shock just as much as you going, what the fuck's going on? Because you're going to be freaking out. You'll notice a massive irregular pulse rate. Ventricular tachycardia and ventricular VFib are very common when you get a myocardial injury. So you can see them go back and forth. Patients will complain, obviously, of chest pain, discomfort, almost just like cardiac symptoms. But it could be because they just go in a massive car wreck and now you want to look for injuries and you're like, oh, God, there's a lot of bruising all of a sudden. Suspect moderate contusion and all severe blunt force traumas, MVCs, motorcycle versus car, anything that involves the body to make a rapid stop and the patient took a sudden impact to the chest. You want to monitor the patient very, very closely. On this one, you're going to treat them for a critical patient. You're going to check them every 5 minutes, and you are going to transport whatever y'all want to call it, priority 1, priority 3, lights and sirens, code 9, I don't know. Y'all come up with your own terms for your agencies and transport them rapidly because they will crash on you fast. Anybody want to guess on how to pronounce that? Komodo cordis? I don't know. We're going.
Cordis.
What is that one?
Comotio cordis.
All right, that's what I thought. All right, I'm gonna stick with that one. So what's gonna happen here? All right, so this is probably this is going to be a result of small direct impacts to the chest. Softballs, baseballs, bats. I don't really believe snowballs when I saw this, but I was like, that's a pretty hard ass snowball. Looks like somebody froze that thing. Getting punched, kicked. This will result into VFib. If they're not defibrillated in the first 2 minutes after the injury, they will go into cardiac arrest. It is not it's not always common for them to get this commotio cordis, but if they are struck in the chest with this and they start to have signs and symptoms, these are going to be more sports related injuries. If the person becomes unconscious and then unresponsive after the blow to the chest, this is the resort of it, and this will be called a Komodo chorus. Now, they may say that they have cardiac tamponade later on, that the heart is bruised, so they're going to tell you more, and you're like, so was I right or was I wrong? Well, no, this is why, but you were right. I just, in the beginning, yes. Laceration to the great vessels. You will notice the great vessels are supravena cava, the inferior vena cava, pulmonary arteries, all four main pulmonary veins, the aorta and its branches. Those are all your great vessels. So that's probably important that you know what those great vessels are. You will be doing CPR if any of these vessels have damage and or they lacerate because they're going to bleed out. You are going to obviously, what they say, cardio, CPR, ventilate, immediate transport, be on alert for shock, monitoring changes for baselines, um, and be alert to any signs and symptoms of shock because they fixing to decompensate super fast. That's because they done. Clark, she done. Um, Folks, I don't really know what else to add. I'm gonna tell y'all this is if y'all have anything else y'all want to suggest to talk about that we add in here, let's do it. Really making some suggestions, but the best thing that I'm think most of you guys want is this right here. Uh-oh. There's your
I
class.
want.
There's your class code for the night. It is the money sign exclamation dash 78. I also copied it in. I was finally able to write in the chat box for some reason tonight. Did somebody have anything they wanted to add?
Yeah, I got a question for you.
Let me hear it.
You said you shocked that patient first.
The one tonight or one this morning?
Uh, Whenever the one you was telling us about.
I was going to, as I was getting ready to shock them. I had pads and everything on them, and he just went down to a 140 rate, 140, 150. I got it on. I got it on the monitor. Got it on strips and everything, where he just
Uh,
out of the cardiac worry about him, and he just. I'm not gonna say he cardioverted, but he changed rhythms.
okay, so what would you would have done if he didn't? Would you shock him first?
Yes, sir. But I gotta get a line. I gotta do IV O2 monitor before I can any IV and O2 before I cardiovert anybody. Because you don't want to cardiovert somebody and not have access for drugs.
Okay. Most medics I work with, they use adenosine first. They say they rather shock last. Do
Well,
you agree?
it's cheap and easy uh, to adenosine, but due to my protocols and I'm so far out here that if adenosine does not work, I don't have a backup.
Mm,
Because it's a 90-minute flight from the time that they're alerted to the time that they land.
good Lord.
90 minutes.
Where you
Mm.
where you work at?
So I work out in the Gulf of Mexico.
Oh, yeah, y'all protocols are different.
Yeah, so we cardiovert first. If we can cardiovert them, then we will change them over to a drip rate and or we can use adenosine, which we have that here. It just depends, but if it does not work, we just killed them. So
Yep.
Yep.
Well, now the class is pretty much over. Does anybody know how many different places, what the 3 different places are to take a blood pressure?
Where we can well, you can check arms, legs.
Isn't it like the foot, the neck, and the arm?
So you're three different places to take a BP. So if you can get one in the arm above the crease of the elbow, you can go for between the elbow and the wrist. And you can also get one if you have a big enough BP cuff, which if your agency has a decent monitor, then you're going to have a large enough BP cuff. You can get one out of the thigh.
Yeah, the thigh.
All right, folks. Y'all got any more other questions? I'm struggling to stay awake, so I apologize. I would love to sit here and talk if y'all want to continue to talking, but big boy going down. I'm telling you, I'm struggling. I ain't got no sleep.
Okay.
I mean, we're good.
All right, folks. Y'all please message me. You can email me if you don't have my email. I'll be more than happy to type it out for you guys. But it's chris.wally at aresmedsolutions.com. Please email me. You can direct message me on Facebook. Sometimes I'll answer right away. Sometimes I may have to delay or read it and I'll come back to you. But again, I'm gonna fuss it. In general, if you have not taken your test, you need to tighten up because there will be, before you move into the next module, and the next module is not big at all, I will be removing some that are failing, and that's for your benefit.
Hey, have I done all my margin?
Alex, hang on, bro. Let me pull that up.
Hey, Chris, a quick question.
Come on.
So, okay, so I know that the website, as far as attendance, is still not working. As long as we're getting the test done and all, are we good, or we still need to be submitting that and sending that to you?
Please send it to me because if there's a question, I can at least look at it. But send it to Rob and myself because not a lot of times that I really, if you send it to me and I have it in an email, I've always got it. I don't delete my company emails, so that
Oh,
send it to us.
gotta,
Alex, you the only Alex, what you listed in Canvas?
Alex John, well, J-E.
I'll see you in here, bro.
It might be up on the Woo Woo Kid.
Oh yeah, I forgot about you.
Should be ashamed of yourself.
I don't. Oh, look at him. So I have a Thurston
Oh,
Jones and a Lysandrio Jones.
Huh?
I'm just telling you. That's all I got.
You got what?
Hold on, I'm trying to pull it back up. The name. I have a Lysandrio Jones and a Thurston Jones.
Oh, I'm Alessandro.
Bro, what you go by? How many first names? Tell me your government names, what I need you to have in here. All right.
Uh,
You're laughing because you know I'm right. Now, you straight up, you got a 95 average.
okay. So I'm not behind on anything
No, I
that
don't
I know of.
know. No, you good.
Okay. All right. I just got my test tonight.
Yep. You got to tighten up on that. Get it done tonight.
I'm gonna do it when we get out of class.
All right. Somebody else say something? Did I cut him off?
that's me, Chase.
Chase, you good?
Question for you. Yeah, question for you.
Yeah.
How hard is it for y'all to order morphine right now and
Huh.
get morphine?
We don't have it. Put it that way.
Don't feel bad because we don't either. And it's on back order for, I think they said right now, 8 months.
Yeah.
8 months.
Mm-hmm. All we have is midazolam.
Yeah, we don't have that. So you're out of luck on that.
I mean, just literally, literally all we got is midazolam, fentanyl, and I don't know why, but our supervisor likes keeping a Etomidate in the narc box. But
Yeah, I know. It's different out here. I mean, I'm telling you, it's and of course our company is fairly large, so we uh we get what we can get. We take it and we roll with it. I promise you. So
but I know. I mean, even for us to be okay, so the company I work for is small. We literally have one 24-hour truck that runs 7 days a week.
hmm
And we only have that truck, and we only have a 12-hour crew. Most of the time, our 12-hour crew Monday through Thursday is ALS, Friday, Saturday, and Sunday is BLS.
wow.
Yeah, like that. I mean, that's how bad it is. And most of our employees work for because it's a lot different up here. Like the volley departments up here are a lot different, just because most of them have rescue squads.
hmm
So they're very territorial out here with 911 calls.
Oh yeah.
So we don't even run 911s unless we're literally called out for mutual aid. Like we're one of the last backups because all of the volunteer departments having rescue squads.
hmm
But most of our employees are out of these volunteer departments.
Yeah. Where are you from again?
I'm up in Defiance, Ohio,
That's
Northwest Ohio.
I got a buddy that's up there on one of the squads. And I can't remember what. I was with him in Afghanistan. I don't remember where he said he was at, but it's different up there.
hmm I mean, and another thing that I looked up that I'm not 100% sure on because I know National Registry is out of the state of Ohio.
hmm
National Registry this year, they're not requiring psychomotor skills. All they're requiring is a cognitive exam to pass National Registry
I
and
know
become.
last year, but I'm not sure how it is this year.
What me and my supervisor looked up the other day, it's good. You can do it up until June 30th and not have to take skills, and then it expires, I think, next year. Whenever it's up, because it'll only be like a year license because you're in the middle of like the 2 years or whatever.
Yep, I've heard that.
Did you get? Oh, I forgot to email you. I guess I need to email you. Did you get any further information about the Louisiana license or whatever?
Uh, brother, I'm gonna tell you to be honest. I honestly have forgotten because so much is going on since I was at home last and coming out here. I apologize. I have forgotten.
You're good. I'll make sure and I'll send you email. I've been on a truck 3 to 4 days a week, and it's during class nights, so I don't. I go to work at 7. I get off at 7. Sometimes 9. It depends.
I get it.
Because we have one dispatcher that literally likes keeping us over the 12-hour crew over until 8, 9 o'clock at night.
hmm
70-something-year-old man that has no clue about dispatching, and we're scheduled out for the day, and he still takes ALS calls, and it's like, well, okay.
Yeah, I got it. I mean, it's different areas, like you said. It all is different.
Right.
So
All right, but yeah, I'll get that email sent over to you tomorrow, and but
no problem. And tomorrow I'll be able to work on it and handle it from there.
well, do some rest.
Appreciate it. Y'all have a great night.
Me too.